I'm Gary Clark, a statistician who has been involved in cancer research for several decades. This morning, I'd like to share some thoughts on biomarkers in oncology trials. So let's start with a definition. The National Institutes of Health Working Group defined a biomarker to be a characteristic that is objectively measured and evaluated as an indicator of normal biologic processes, pathogenic processes, or pharmacologic responses to a therapeutic intervention. Now, this is a rather broad definition that could include many different types of biomarkers. For example, a biomarker could be used to make a diagnosis or to make a risk assessment. Think of PSA for diagnosing prostate cancer, or the various breast cancer genes for assessing the risk of developing breast cancer. Biomarkers can be used for prognosis or estimating the natural history or creating a staging system. So think of lymph node status or tumor size. For most cancers, these factors are correlated with a poor prognosis. Biomarkers can also be used to predict response to a specific therapy. So for example, anti-estrogens require an intact estrogen pathway. So the estrogen receptor, progesterone receptor status will help predict which patients will respond to that therapy. Similarly, drugs like trastuzumab or Herceptin require the activation of the HER2 pathway. Biomarkers can also be used to monitor response to therapy. For example, serum factors such as CA125, CA15.3, or CEA can be used to monitor the response in breast cancer patients. Sometimes biomarkers simply become targets for therapy and allow us to select patients for specific treatments. So for example, HER2 or EGFR mutations or ALK translocations all led to very specific, target-specific therapies, starting with some biomarkers. So what I want to do for the next period of time is to focus on prognostic factors and predictive factors and try to distinguish the two. So several years ago, when I was working in breast cancer, we defined a prognostic factor as any measurement that is associated with clinical outcome in the absence of therapy or with the application of a standard therapy that all patients are likely to receive. So a prognostic factor is really a predictor of the natural history of the tumor without any outside experimental therapies. So it's not related to a treatment. A predictive factor is a little different. It's any measurement that is associated with response or lack of response to a particular therapy, where response can be defined using any of the clinical endpoints that we use in clinical trials. So predictive factors like the estrogen receptor are predictive and associated with anti-estrogen therapies. HER2 is a predictive factor when it's associated with treatment with, say, Herceptin. So here are a lot of different common clinical endpoints that we use for biomarker studies. The point of this slide is to say that a biomarker is actually associated with a clinical outcome, especially when we're talking about predictive factors. And to remind you that a predictive factor for tumor response may or may not be a predictive factor for, let's say, disease-free survival or overall survival. The point is we have to validate the prognostic or predictive effect together in combination with a particular clinical endpoint. So let's suppose that we have a new drug that was designed to be effective in patients with marker X. And we ask the question, what types of clinical trials should we design? Now, this clinical trial needs to evaluate the drug, but it probably needs to evaluate the marker at the same time. So let's start talking about patient selection. Now, if we are really confident that the therapy will not work in marker negative patients, and we have a validated assay that can reliably assess the status of the market, then perhaps a single arm study in just marker positive patients might make sense. So let's conduct such a trial. So here we have marker positive patients. They were all treated with a targeted therapy, and we have this wonderful survival curve with a median of 12 months. So what have we learned from this particular trial? Well, maybe we should ask the question the other way around. What do we not know based on this particular survival curve? Well, obviously the survival curve, it depends on what the patients were. They're marker positive, but are they breast cancer patients, lung cancer patients? We also have no idea what would have happened to these patients if we didn't treat them with a targeted therapy. Clearly, the survival curve is influenced by the prognostic effects of marker X, if they actually exist. We cannot determine if the targeted therapy confers a meaningful benefit over standard therapy in this marker positive subgroup because we don't have any patients who were treated with standard therapy. And if we don't have any patients treated with the standard therapy, then we cannot assess the prognostic value of the marker. Remember how I defined a prognostic marker, something that was associated with a clinical outcome with standard therapy or with no therapy. And if I can't assess the prognostic value, then I cannot assess the predictive value of marker X. So I'm not sure how much we learned by doing a single-arm study in simply marker positive patients. Well, what if the therapy works a little bit in marker negative patients? Or what if the marker is prognostic? Perhaps a two-arm study would be better. But then the question is, which two-arm study? Well, here are a couple of different study designs. Can we study unselected patients treated only with a targeted therapy? So the idea is we would treat all patients with a targeted therapy, and then we would compare those patients that had a marker positive or a marker negative phenotype. Or another two-arm study would be, how about can we study an enriched population only? So let's only study marker positive patients, but now let's introduce a standard therapy and compare the targeted therapy versus the standard therapy. So let's examine each of these designs in a little more detail. So can we study unselected patients treated only with the targeted therapy? So here's a good example. We treat the patients, they've all been treated with the targeted therapy. Lo and behold, those who are marker positive have a better survival than those who are marker negative. So what have we learned by doing this study? Well, we can probably say that the marker positive patients treated with targeted therapy do better than marker negative patients, but what don't we know? Well, we have no idea what would happen if we had treated them with some other therapy, say a standard therapy. So the bottom line is we really need a control group to draw definitive conclusions. Well, what about studying an enriched population only? So now we're going to take just the marker positive patients. We're going to treat them, randomize them, and treat them with either standard therapy or targeted therapy. And we have a wonderful survival curve. And we can draw the conclusion that says, if you have a marker positive patients, they are going to benefit more from the targeted therapy than they will from the standard therapy. So that's a good conclusion, but I would suggest that we've only answered half of the real question, because we really don't know what would have happened if we would have treated the marker negative patients. Now, granted, the chemists who created this molecule that turned into a therapy told us that it's not supposed to work in marker negative patients. But we've all been surprised when we introduce a new therapy into human patients. Sometimes what we think is supposed to happen doesn't always take place. So what I'd like to do now is, we've conducted this study. We know what happens in the marker positive patients. Let's imagine what could have happened if we had included marker negative patients. So I ask you to imprint these survival curves in your brain, and I'm going to overlay some marker negative patients. So again, we have unselected patients. We haven't worried about what their marker status is. We treat them all with either a targeted therapy or a standard therapy. So that imprinted image that I told you to remember for the marker positive patients is in the upper part of the graph. Here's the standard therapy. Here's the targeted therapy. There was a marked benefit in the marker positive patients. In this particular example, in the marker negative patients, the chemist was right. There was no benefit from adding the targeted therapy to standard therapy if they were marker negative. Well, let's go back and assess a few things. How do we assess whether or not the marker is a prognostic factor? Well, we look at the untreated population, or in this case, those treated with standard therapy. And we can see that the standard therapy for marker negative patients, the standard therapy for marker positive patients gives you exactly the same outcome. So in this situation, the marker is not prognostic. Without the introduction of the targeted therapy, the patients will have exactly the same survival curves. So the marker is not prognostic. It is predictive, however, because there is a differential benefit. In the marker negative patients, there's no benefit. In the marker positive patients, there is a benefit. That's a definition of a predictive factor. So in this situation, that two-arm study that you conducted in just marker positive patients pretty much answers most of the question. You should treat the marker positive patients, and then by implication, we really didn't know anything about the marker patients, but we assumed the treatment was not going to work. And in this situation, that was a correct assumption. Let's look at a little different scenario. Same marker positive group, same benefit from the targeted therapy, but now in the marker negative group, we see something that's a little bit different. If we look at the standard therapy, the patients with marker negative have a worse outcome, a worse survival with standard therapy than the patients in the marker positive group. So that comparison right there is the definition of a prognostic factor. So marker positive patients do worse than marker negative patients if you treat them with standard therapy. That's prognostic. Now, the benefit in the marker positive patient is quite great. The benefit in the marker negative patients, well, if anything, the marker negative patients did a little bit worse with targeted therapy than the standard therapy. So once again, it's a predictive factor for a benefit in the marker positive patients. But this marker now is both predictive and prognostic. And once again, the conclusion that you drew from the marker positive subset was the correct conclusion. The treatment works in marker positive patients. It doesn't work in the marker negative patients, just as predicted by your chemists. So that two-arm study in the marker positive group pretty much answers most of your questions. Well, there's a third possibility. Once again, the marker positive patients is the same one that we've seen before. Now we treat marker negative patients, and guess what? We get exactly the same outcome in the marker negative patients as we got in the marker positive patients. So if we compare the survival with standard therapy, the marker negative patients and the marker positive patients have exactly the same survival. That means the marker is not prognostic. It doesn't help you decide which patients to treat with standard therapy. The relative benefit is exactly the same in marker negative patients and the marker positive patients. So in this situation, the marker is neither prognostic nor predictive. In fact, the marker is totally useless. It has no relationship to natural history. It has no relationship to a benefit from therapy. So while your conclusion is correct, in marker positive patients, the targeted therapy is better than standard therapy. It's also correct in the marker negative patients. So now what we've done is we've not had the ability to learn the outcomes in the marker negative population if we just performed the two-arm study in marker positive patients. So sometimes this one is a little more confusing. The marker positive patients, exactly as we have seen before, targeted therapy improves the survival in the marker positive patients. In this case, if we look, is there prognostic significance? Under standard therapy in the marker negative patients, they do worse then standard therapy in the marker positive patients. So this is a prognostic factor. Without the introduction of the targeted therapy, the patients with positive marker do better than the patients with a negative marker. But again, the benefit, the relative benefit, if you add the targeted therapy to the standard therapy is exactly the same in the marker negative patients as it is in the marker positive patients. So the conclusion that you drew from your 2-arm study is we should treat patients who are marker positive with the targeted therapy is correct. But what you've missed by not studying the marker negative patients is you should also treat the marker negative patients with the targeted therapy because they're going to benefit just as much as the marker positive patients. So my take-home message here, well, let's do a little bit more. So this is a prognostic marker that is not predictive. Now, the most informative design is to look at all 4 subsets. So I would suggest that what we might want to do is first measure the marker status so that some patients are going to be marker positive, some patients are going to be marker negative, and there will probably be a subset of patients that will be marker unknown, depending on how good your assay techniques are. We could randomize within the marker positive patients and within the marker negative patients to either targeted therapy or standard therapy. And at the end of the study, we would have 4 survival curves. We could then assess both the prognostic significance of the marker and the predictive significance of the marker to tell us whether the targeted therapy is really better than standard therapy. Now, the problem with this design is the sample size could become very, very large, especially if the prevalence of the marker is something other than 50-50. I mean, some of the markers that we're looking at today have a prevalence of less than 10%. So that means in order to get a sufficiently large number of patients that are marker positive, we would have to study a very large group of patients. So this is a situation where more complicated adaptive designs might be more efficient in certain scenarios, but we still, at the end of the day, would like to be able to compare all 4 subsets. So my first take-home message today is that it is critical that we separate the prognostic effects from predictive effects before drawing conclusions about the clinical utility of biomarkers. There's a good chance that we could be making a mistake by not studying certain subsets simply based on prior assumptions that may or may not be correct. So those were nice made-up examples that I gave you. The question is the issue of prognostic versus predictive really a problem in practice? Let me give you a real-world example. Back in 2005, when EGFR inhibitors were first starting to become evaluated, there were some papers published in the literature. So here is one from the Journal of Clinical Oncology, nice reputable journal, entitled Practical Management of Patients with Non-Small Cell Lung Cancer Treated with Gefitinib, an EGFR inhibitor. And this table is taken verbatim right out of that paper. What the authors did is they described some factors that you could determine before you started treatment that would predict sensitivity to gefitinib, and some factors that do not predict sensitivity to gefitinib. So for example, patients who never smoked cigarettes, patients who had essentially adenocarcinoma, females, and those born in Eastern Asia are all supposed to predict for sensitivity to gefitinib. However, the type of prior chemotherapy the patients had received, the number of chemotherapy regimens, and perhaps a little surprisingly, the presence or intensity of EGFR staining by immunohistochemistry did not predict sensitivity to gefitinib. So there's a different paper that came to the same conclusion. Non-smokers, women, patients with adenocarcinoma are more likely to have major objective responses than other patients. And remember that gefitinib was not approved at this particular time. It is reasonable to move gefitinib into second-line therapy for patients who are known to have a tumor that is more likely to respond to gefitinib. Also, I would treat such patients with gefitinib as first-line therapy on an appropriate clinical trial approved by the Institutional Review Board. So let's think about this for a minute, or let's analyze it. Let's talk about non-smokers, women, patients with adenocarcinoma. These conclusions were all based on randomized phase 2 trials of gefitinib. These studies were designed to evaluate 2 doses of gefitinib. There was no control group, and the primary endpoints were tumor response and symptom benefit. Now, I asked the question, would these conclusions still be true if these clinical trials had included a control group? So think back to those 4 scenarios that I showed you, demonstrating the difference between prognostic and predictive effects. So this was kind of a 2-arm study here, basically, right? And let's also introduce another confounding factor. Would the conclusion still be true if survival had been the primary endpoint? So fortunately, at this time, there was another EGFR inhibitor called erlotinib, or Tarceva. And this study was a phase 3 trial conducted by the National Cancer Institute of Canada Clinical Trials Group, and it's known as BR21. All of these patients had non-small cell lung cancer. They were stratified by study center, performance status, response to prior therapy, the number of prior regimens, prior platinum, and they were randomized to either erlotinib or an identical placebo tablet in a 2-to-1 randomization. And again, note that prior regimens were 1 versus 2, which means this was 2nd or 3rd line therapy for these particular patients. So eventually, gefitinib was given accelerated approval based on the phase 2 studies. And from the package insert, we can see that the females had a better response rate than the males. Patients with adenocarcinoma had a better response rate than patients with other histologies. And non-smokers had a very good response rate compared to previous or current smokers. And fortunately, because it's in the same class of inhibitors, erlotinib from the phase 3 study also had a better response rate for females than males, a better response rate for adenocarcinoma or other histologies, and a better response rate for non-smokers. These results are very, very similar, which would seem to support all of those conclusions that were included in the publication. And actually what happened is the clinicians who were treating such non-small lung cancer patients took away the conclusions that the patients had better be either a female, have adenocarcinoma, or non-smoker before we would administer either of these EGFR inhibitors, and that males, patients with other histologies, and previous or current smokers probably shouldn't receive these inhibitors, and other therapies might be more appropriate. Well, let's look further at the results of the study BR21. Remember, survival now is the primary endpoint in this study. And here's the erlotinib arm, and we've divided the survival curves by gender. And notice that the females have a better survival than the males, median of 8.4 months versus 5.7 months, a nice hazard ratio. So once again, this seems to support the conclusion that we should be treating the females and not the males. But this is just the erlotinib arm. I wonder what happened in the placebo arm. Aha, almost exactly the same outcome. Now the actual median, the actual survivals are less. The median survival is 6.2 now versus 4.5 females versus males, but obviously the females are doing better when they received placebo. This is a classic definition of a prognostic factor. If you give them a placebo, the females do better than males. If you give them Tarceva, females do better than males. So here are the two groups side by side. There's a lot of white space on both sides. The hazard ratios are nearly the same, but if gender had been a biomarker, and we had selected the patients based on the favorable part of the biomarker, the marker positive patients in this case are the females, this would be the enriched population. So this is where we would draw the conclusion. We would say, yes, treat the females. And then almost by implication, the answer would be, but don't treat the males. And this would be the unstudied population. So we would never have known that this drug worked in the males if we had only selected the biomarker positive female subset. And if we overlay both of these curves, you can see what happens. The males treated with placebo have a worse survival than the females treated with placebo, but the improvement by adding erlotinib in the males in a relative sense is exactly the same as in the females. Now, the males with erlotinib don't have the same outcome as females with erlotinib, but you have to remember where they started with placebo. So we would have missed something if we would only had looked at the marker positive patients. This was gender. What about histology? Well, here's survival by histology in the erlotinib arm. And yes, indeed, the patients who have adenocarcinoma have a much better outcome than the patients who had squamous cell. But this is the erlotinib arm. What about the placebo arm? Just like gender, histology is prognostic. Patients who were treated with placebo, who had adenocarcinoma, had a much better outcome than patients who had squamous cell carcinoma. And if we put them side by side, there's a lot of white space between both of them. The curves are different again, just like they were with gender. Hazard ratios, however, are just about the same. But now, if histology had been the biomarker, and we had selected only the marker positive patients, this is the only outcome that we would see. We would draw the conclusion that we should only treat patients who have, or we should treat patients who have adenocarcinoma with erlotinib. They're going to benefit. And we would either conclude that patients with squamous cell were not going to benefit, or we would have to be honest and say we actually don't know what happens, because this would be an unstudied population. And just like in gender, these two curves demonstrate a prognostic effect, but not a predictive effect. You get the same relative improvement treating males as you do females. Can we go 3 for 3? The other factor that we talked about was smoking. So here is the erlotinib arm. Never smokers have a much better outcome than current or former smokers. What do you think is going to happen in the placebo group? Well, you might be a little surprised because in this study, smoking was not prognostic. If you treat the patients with placebo, the never smokers had pretty much the same outcome as current or former smokers. Now you might ask, well, why? How is that possible? We all know that smoking is bad for you. So certainly if you just let smokers and current smokers be untreated, given a placebo, the smokers must do worse. Well, I would remind you that this study is second and third line treatment of non-small cell lung cancer patients. So the patients, the smokers, when they were treated during first line therapy, probably didn't do very well, or even if they did, they may have had a deterioration in performance status and may not have been eligible for this second and third line study. So I think there's a little bit of a selection bias going on, but nevertheless, within this phase 3 study, smoking is not prognostic. And so now when we put the curves next to each other, we see that there was a big benefit in the never smokers and not such a big benefit. There's still white space between the erlotinib and placebo curves for the current and former smokers. But when we overlay them, you can see the big benefit now is in the never smokers. So now we have a factor that is not prognostic, but it is very clearly predictive for a differential benefit for the never smokers when they are treated with the inhibitor. So if we didn't know anything about the prognostic significance of these 3 markers, we would never have come to these conclusions when we had the full study. So the second take-home message is that patient selection early in drug development runs the risk of selecting the wrong biomarker and/or the wrong assay. So my advice regarding patient selection is, do not use selection or enrichment strategies too early unless you are absolutely certain of target functionality and you have a validated assay that can reliably assess the status of the biomarker. I can show you several examples in the literature where it's been the wrong biomarker or the target functionality is in question because we've used the wrong assay. I do suggest that we collect tissue samples to obtain preliminary information about biomarkers in early development studies so we can generate appropriate hypotheses for future definitive studies. And I hope I've demonstrated to you that we might want to conduct randomized clinical trials with appropriate control arms fairly early in development, especially if you have brand new biomarkers that have never been assessed before. So we have no historical comparisons or basis of comparisons until we do some kinds of studies, and randomization may help us a lot. So now I'd like to switch to a different topic, but very, very much related. So depending on the type of assay we use to measure the biomarker, we may want to think about a cut point. So if we have a simple assay such as, let's say we're looking for a mutation. Well, you either have a mutation or you do not. So all we need to worry about is what is the definition of a mutation. But perhaps we're measuring something on more of a continuous scale. If we're measuring protein expression, we could have low expression and various degrees of expression. And we may want to find a cut point such that we can call them marker negative or marker positive. And how do we do that? Well, we can look in the literature, and very often you will find that if there's a brand new biomarker, sometimes the scientists simply use the median. And they just say, I'm going to find a value such that 50% of my population is marker negative and 50% is marker positive. I don't think that's a very good way to select a cut point, because there are very few diseases that I can think of where half of the patients are going to have a good outcome and half of the patients are going to have a poor outcome. So sometimes you see people using the lower quartile, with just the lower fourth of the patients, or the upper quartile, the upper fourth of the patients, with respect to that particular biomarker. Sometimes you see a value that is selected from previous literature, but when you go back to the previous literature, you really don't know how that one was selected. And there's quite a number of studies that are reported that use what's called an optimal cut point that is based on a correlation with a clinical outcome. So here's an example of that. Let's suppose that we have a biomarker and there are 6 possible outcomes, from 0 to 1 to 2 to 3 to 4 to 5. You can think of certain immunohistochemistries that are marked kind of like this. So if there are 6 potential outcomes of the biomarker, there are 5 cut points. If we use a cut point of 1, what we're really doing is say, let's call a value of 0 to be marker negative, and then values of 1, 2, 3, 4, or 5 will be positive. And if we do that and we calculate the survival curves for the cut point at 1, we see that there's really no separation between the two. Then we say, well, what if we use a cut point of 2? So in this case, we would combine the values of 0 and 1 and call those low, and we would take 2, 3, 4, and 5 and call those high or positive. Now we see a little bit of a separation between the survival curves. If we move the cut point up to 3, so marker negative now becomes 0, 1, or 2, and marker positive becomes 3, 4, or 5, now we have a lot of white space between the two, and we have this nice statistically significant p-value of 0.01. If we move the marker up to 4, we start losing significance, and if we move the cut point up to 5, it's gone altogether. And so we would conclude this must be the best cut point. This is the optimal cut point in our search for cut points. The question now becomes, well, if we were to use this optimal cut point on a new group of patients and conduct a new study, Are we going to get a true positive and they'll separate just as much? Or might we get a false positive and when we try to validate it, they come back together again? So a long time ago, way back in 1992, my colleague Sue Hilsenbeck decided to ask this question. She wanted to investigate the problem of false positives when continuous biomarkers are dichotomized. This is a fun little paper that we called, "Why do so many prognostic factors fail to pan out?" So what she did, she was a statistician like me, so she didn't generate or didn't treat patients, but instead she made them up. So using the computer, she generated clinical studies of about 250 patients in each study, randomly generated some biomarker values, randomly generated some recurrence times such that the 5-year disease-free survival was around 70%, with an average follow-up of about 6 years. We used these criteria because we came across quite a few papers in the literature around that time that were roughly sized and had the same type of a population of breast cancer patients. She then did several studies, and I'm just going to show you the results of one of them. In this particular study, she said, let's suppose that the biomarker has no correlation with disease-free survival. So no matter how you cut and slice the biomarker, it is totally independent of the clinical outcome, disease-free survival. And she then looked at different scenarios. The scenario where there was only one possible cut point. So again, the idea that you have a mutation or you do not have a mutation, there's only one cut point. Then she said, what if there's 2 cut points? So there's 3 different values, low, medium, and high, but I only want 1 cut point. What if there's 5 possible cut points, 10, 15, 20, 30, 50? So every one of these times was a different scenario. She ran each scenario 200 to 300 times. That means she generated that many clinical trials. And what she was doing is looking for a cut point to divide the biomarker into 2 sets. She calculated what we call a log rank p-value to compare the marker positive versus the marker negative subsets. And she did that for every single one of the possible cut points of the biomarker. And she counted the number of runs, or the number of clinical trials, that yielded a cut point of p less than 0.05. And that would be an indication of a statistically significant differentiation identifying a biomarker. And here's what happened. If there was only 1 cut point, so first of all, remember the null hypothesis here is that there is no effect. And we're assuming that that is true. The biomarker is totally independent of the clinical outcome. So when there was only 1 cut point, she found one 5% of the time. That's exactly what you do if you have a level of significance of 0.05. You say my false positive rate, the acceptable false positive rate is 5%. That's exactly what the computer program spit out. Now, if there were 2 cut points, rather than finding a cut point only 5% of the time, it found one 10% of the time. So in other words, the false positive rate was doubled by simply asking 2 questions instead of asking 1. And as the number of potential cut points increased, the number of false positives also increased, such that by the time we got to roughly 50 possible cut points, the false positive rate was 40%. So 40% of the time we identified, or the computer identified, a quote, statistically significant cut point that really does not exist. Now, to prove that the computer program worked properly, every time she found a statistically significant cut point, that is a p-value less than 0.05, she generated a new clinical trial and used that cut point to see if it would validate and become a true positive result. And what happened is every time she validated it, for every single experiment that she ran, the cut point only validated 5% of the time. Once again, that's exactly what you would expect if you're testing at a level of significance 5%. So you generate false positive results by conducting multiple tests of hypothesis. So how do we deal with this problem? Well, the ideal situation is to have separate training and validation sets of data, either by dividing your clinical trial into two sets randomly, or even better, to get a totally separate clinical trial, a separate set of data, train and find the cut point on one set, on one study, and then validate on another study. Or you can use internal validation techniques, such as what's called the jackknife technique or bootstrap technique. Or we make p-value adjustments. We don't test at 0.05 to find that cut point. We test at something much smaller. And sometimes it has to be really, really small if you have many, many different tests of hypothesis. So my third take-home message is that even modest data exploration runs a serious risk of finding an effect, or in this case, finding a biomarker, a cut point for a biomarker where none exists. And I didn't show you the other results that she produced, but she also did the same study where there really was a relationship between the biomarker and the clinical outcome. And what she discovered is that you overestimate the importance of a new biomarker if you use this optimal multiple hypothesis testing approach to identify the cut point. So my bottom line here is validation is essential. You can't just train on a data set and find a positive cut point. You have to train and then validate again and validate again. And I think in this day and age, in order to validate a cut point, in order to get a cut point published in the literature, you probably need to validate on 2 or 3 external different data sets to make sure that you have a true positive rather than a false positive. So my final take-home messages for this presentation is that good biomarkers have a solid biological rationale. You have to start with a good idea as a foundation and then do the testing, the experimentation to determine whether that biomarker is going to be clinically useful. Evaluation of biomarkers requires validated and reproducible assays with predefined scoring systems and cut points. What you read in the literature is, well, we modified the assay by Smith et al. By doing something. Well, if you modify the assay, it's a different assay. It may or may not have the same validation properties as the one that you just did. Biomarker studies should be designed with the same rigor that is used to design clinical trials of new treatments. The problem with biomarker studies is that you're looking at subsets of populations. So the sample size that you really need to come with definitive conclusions is much, much larger than the sample size you need to show that a new treatment is better than a standard treatment. And we need to keep that in mind when we draw conclusions from such studies. And finally, to go back to the beginning, it is critical that prognostic effects are separated from predictive effects before drawing conclusions about the clinical utility of biomarkers. I want you to think back to those 4 scenarios that I showed you and think about the consequences if you decide to draw conclusions from a 2-arm study. So I'd like to leave you with a few references. So I was very fortunate to be part of a working group on cancer diagnostics that was a joint collaboration between the National Cancer Institute in the US and the EORTC. And we produced some reporting recommendations for tumor marker prognostic studies. They're now known as the Remark Guidelines. And these guidelines were published in multiple journals. They're the same guidelines. It's a nice way to pad your CV, is to get them published in different journals. And then quite a few years later, my colleagues published another paper that is probably even more important. It's the Remark Guidelines with additional explanation and elaboration, and it was published in 2 different journals. So any of you who are going to be involved in biomarker studies, either conducting them, designing them, or even just reading the literature and trying to interpret the results of other people's studies, these Remark Guidelines, I think, will be very educational and very helpful to you. So I thank you for your attention and hope you have a wonderful workshop.